Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Respiratory Issues in the Older Adult, Episode 3, COPD. After viewing this episode, participants will learn about the epidemiology and pathophysiology of COPD. Participants will review the abnormal physical exam findings seen in older adults with COPD. Finally, participants will review treatments for COPD in the field.
COPD is chronic obstructive pulmonary disease, and it's made up of three diseases, which is chronic bronchitis, emphysema, and asthma. And each of those components can be in a different balance in different people. What causes COPD is number one, the emphysema component is with chronic inflammation of the lung. The alveolar sacs break down so that you don't have as much surface area for absorbing and exchanging oxygen. The other component is the bronchitis, inflammation of the airways. So there's a narrowing and an increased mucus production within the bronchi and bronchioles, which causes more coughing and difficulty exchanging air. The third component is an asthma component, so the reactive airways, when exposed to something irritating, the airways will constrict, and that's the asthmatic component. COPD is commonly an accumulation of damage to the lung due to environmental predispositions or exposures, excuse me. So that damage accumulates over time. So COPD definitely becomes more common in the older patient.
COPD is very common among geriatric patients. It's the fourth leading cause of death in this country. It is basically, at least in this country, a disease of nicotine abuse or cigarette exposure. So it tends to accumulate in those who have had either a history of nicotine abuse or ongoing cigarette smoking. So COPD exacerbations tend to accumulate in the wintertime, although they can be year-round. We believe that at least half, and most people will argue probably 2/3 of COPD exacerbations are caused by infections. The remainder occur for reasons that we either don't know or sometimes because of some inflammatory exposure that patient finds very irritating, and they have a resultant COPD flare. So with the majority of these being infectious, they tend to occur in the wintertime, especially December, January, and probably the lowest frequency of admissions for COPD exacerbations are in the summer, August in particular.
COPD stands for Chronic Obstructive Pulmonary Disease. COPD is a grouping of three major chronic respiratory diseases, including emphysema, chronic bronchitis, and asthma. All are associated with reduced airflow and shortness of breath. The main causes of COPD is smoking and chronic exposure to smoke.
The exam findings of a COPD exacerbation, again, when you inspect the patient, there can be various degrees of respiratory distress. On percussion, the chest itself might appear somewhat hyperresonant. There's always the possibility of cyanosis, meaning bluish discoloration from low oxygen levels. And the lung exam is very variable. You can hear rales, you can hear wheezing, which is fairly common, or you might hear very diminished lung sounds overall. And all those things can be seen in varied COPD exacerbations. Well, the symptoms of COPD are variable, and they're primarily some combination of chronic cough, chronic shortness of breath with exertion, and chronic sputum production. Sometimes you have just one, or sometimes you have all three of those elements.
Shortness of breath and chronic cough are common symptoms associated with COPD. Increased respiratory rate, decreased activity to compensate for the decreased ability to exchange oxygen, and wheezing are all associated with COPD. In an exacerbation, the airways may become so tight that the finding will be decreased air movement sounds, so or poor air movement. So it might be less sound than you would expect in a patient with that much respiratory distress. There may be a prolonged expiratory phase, so they'll be breathing out for a lot longer than you would expect. And then, of course, you would find the increased respiratory rate. It would be very difficult in an exacerbation sort of phase, which may be the most common EMS setting, to differentiate the types. But the types that are typically taught are what we would call the pink puffer, and they tend to be more of the emphysematist type, and the blue bloater, which is more of the chronic bronchitis. When entering a home setting, I would be looking for the smell of tobacco smoke. You may find oxygen tubing around, nebulizers, and those would all tip you off that this may be a person with chronic obstructive pulmonary disease. The tobacco smoke would be an exacerbator of COPD because it would increase the asthma component. Also, if this person may have some allergies, so times of years where allergies are more common, ragweed season, or they may have reactive airways to cold weather. Those might exacerbate a COPD patient.
Patients with COPD will frequently have a smoking history. Patients will present with signs of labored breathing, pursed lips, use of accessory muscles, sit in a tripod, and have a barreled chest.
COPD is treated in two different ways. In a COPD exacerbation or a flare of COPD, our therapy is typically oxygen support if needed. We give a burst and taper of glucocorticoids either by pill or in the vein. We use bronchodilators, meaning some inhaled therapy to help open up the breathing tubes, and typically an antibiotic because there is a high likelihood of there being some either bacterial or viral trigger for the COPD exacerbation. In addition to that, we use a lot of supportive therapy, which sometimes includes diuretics and sometimes respiratory support, either with CPAP or BiPAP or sometimes invasive mechanical ventilation. In chronic stable COPD, meaning the person who is living in an environment with some fixed obstruction of their airways, which is chronic in nature, we treat them with largely oxygen if needed. We give them bronchodilators, and we have a particular formulation that we typically apply depending upon how severe the COPD is. We strongly encourage quitting smoking, which is sort of the driving factor of the COPD to begin with. We make sure that they get their vaccinations, meaning a flu shot every year, a pneumonia shot at certain points in their life. And we try to encourage them to participate in pulmonary rehabilitation, which is one of the ways that we stop the downward spiral of progressive symptoms and progressive deconditioning that tends to accumulate in patients with advanced COPD. The pre-hospital care or the various subsets of COPD exacerbation are pretty similar. In fact, the inpatient care of these various subsets of COPD are pretty similar. The foundation of therapy is going to be oxygen if it's needed, bronchodilators, meaning various inhaled therapies to help open up the airways, typically antibiotics, regardless of whether there's clear evidence of infection or not, and glucocorticoids, meaning prednisone or the derivatives of prednisone, either given in pill form or given in IV form.
Treatments for COPD exacerbation in the field includes proper positioning of the patient, supplemental O2, bronchodilators, CPAP, and possibly artificial ventilation. After viewing this episode, participants will learn about the epidemiology and pathophysiology of COPD. Participants will review the abnormal physical exam findings seen in older adults with COPD. Finally, participants will review treatments for COPD in the field.